Hello and welcome to our panel. My name is Andrea Sinus, NXT team member at Nexus Marketing and your moderator for today's panel. Today's panel topic is optimizing healthcare revenue cycle, best practices and technologies. As usual, before I introduce our panelists and we jump into this fascinating topic, I do have some logistics to cover. Annex Unite by Nexus Marketing serves as a powerful community resource designed to foster connections and facilitate lasting relationships within the mission-driven sector. On NX Unite, you can find upcoming industry events, suggested influencers to follow, trusted solutions, and cause-driven podcasts. Annex Unite also hosts webinars, demos, and of course, panels with experts such as these lovely folks with me today. Today's 45-minute long panel will include time both for questions curated by my team and questions from you all, our lovely audience. At any time during the panel, please feel free to submit your questions via the chat. We will spend the second portion of the panel addressing as many as we possibly can. Finally, before I introduce today's panelists, I do want to thank you all for attending this panel. We are very excited to be in touch with you, the mission-driven community. Thank you for taking the time to be with us today and to learn from these outstanding experts who I will now finally introduce. We have with us today Courtney Yadeva. Courtney is the Director of Patient Accounting at MedCycle Management and specializes in patient accounts, strategic communication, and operational leadership to drive revenue cycle performance. A self-published author and advocate for improving the patient financial experience, she combines compassion with strategic insight to advance both organizational outcomes and patient well-being. Courtney, welcome to the panel.
Thank you for having me. It's good to be here.
And joining us is Greg Keilin. As co-founder and strategic growth advisor at Prosperity, Greg has 10 plus years of experience in finance and corporate strategy. He has assisted in the evaluation, execution, and integration of multiple behavioral health M&A transactions and implemented plans for data-driven revenue cycles to help customers grow. Greg, welcome to the panel.
Thanks so much. Good to see you, everyone.
And last but not the least, we also have Megan Broom. Megan is the Senior Director of Product Sales at IMO Health. Over the years, has played a pivotal role in helping healthcare organizations enhance clinical data quality and leverage terminology solutions to make more informed, patient-focused decisions. She brings deep industry knowledge and a passion for solving complex challenges that impact care delivery and health outcomes. Thank you for your time, Megan.
Thanks for having me. Looking forward to the conversation.
All right, now that I've formally introduced all of our panelists, we are now going to jump into our first question of the day. What are the biggest pressure points providers are facing right now in revenue cycle management, and how could they mitigate them? And Courtney, we'll let you start us off with this one.
Thank you. Great question. So what I have seen in our industry is really the pressure to maximize current workflow with also little or limited resources. As we shift in this stage that we're in right now with different AI technologies and tools, moving from a reactive to a reactive and preactive RCM is going to be a big step that we're all taking. Providers facing different areas of opportunity to adopt AI tech for claim scrubbing and predictive analytics to catch errors will really help mitigate pressures around complexities.
All right, thanks so much, Courtney, for starting us off. And before I jump into the next panelist, I want to acknowledge Thomas Stewart, who is also one of our panelists. And we had some technical difficulties. But Thomas, thank you so much for being here today and for really treading through despite the technical difficulty. I'll just briefly introduce him quickly. Tom is the president, CEO, and co founder at JTS Health Partners and brings over 16 years of leadership in healthcare professional services and analytics. As a certified public accountant with extensive experience in healthcare consulting, Tom is dedicated to delivering tailored solutions in operational consulting, financial management, and information systems. Again, Tom, thank you so much for your time. All right, jumping back into the question. Thank you so much, Courtney, for starting us off. Greg, anything you would like to add into the biggest pressure points providers are facing right now in revenue cycle management?
In the industries that we work in at Prosperity, which are primarily substance use treatment and mental health treatment, those are historically areas where a lot of providers have been out of network. And there are a variety of reasons for that. But over the last few years, we've seen increasing pressure in a variety of different ways in terms of payer behavior and reimbursement rates and some other areas for providers to start to move to more of an in-network posture. And that is something that a lot of the providers that we work with, who tend to be small and mid-sized companies, frankly, most of the behavioral health companies that exist today in the United States are small and mid-sized companies. A lot of those folks aren't savvy with respect to managed care contracting, payer negotiations, and also there's been sort of a bit of a rush to shift the posture as out of network has become more challenging for our providers. And so that's led to two things. One is that folks have accepted rates and terms that are really unfavorable because they're seeking to just get into the networks at any cost. And then the second related development is that the networks have become really saturated. And so it's increasingly difficult for folks to even get into payer panels these days. So I would say that's for the companies that we work with, that's been one of the biggest pressures in the last couple of years, really shifting their business models around the contract status.
Thank you so much, Greg. Megan, anything to add to what Greg and Courtney just said?
Yeah, I agree with all the challenges that they've outlined. IMO Health, our solutions are primarily provider facing. And so we hear, probably uniquely and pretty loudly from them around all of the pressure points and the, frankly, administrative burden, that is being pushed to them. But it's really critical that they're good at the administrative burden that is tasked to them, because if not, they get two consequences. One is lower reimbursement, either for their system or in a lot of cases that even directly translates to their own personal reimbursement. And so they receive the penalty if there's any sort of gaps that are not addressed up front, or you guys can think of all of the million administrative check boxes that now we require providers to do. And the second consequence outside of lower reimbursement for themselves is they borrow more administrative burden, because if you don't get it right the first time, now you're getting coding queries, now you're in peer-to-peer reviews. So it's a lot of non-provider friendly tasks that we ask them to do. And if they're not successful in it, it just buys more negative things for them. And so I think that that's one of the pressure points that those of us that are able to create, to Courtney's point, well integrated solutions into the workflow, because that's where all of this has to happen, and really making that moment of documentation count and being able to give them the tools and the technology and leverage AI where appropriate to actually help decrease that burden, I think is going to be the key to kind of changing that curve that we see today.
Thanks, Megan. Tom, any final thoughts here? Oh, Tom, I think you are on mute. There you go.
Yeah, thank you very much. Just to add to the panel's comments, our customers are typically hospitals and health systems in the community environment. When I look at the largest pressures that we've seen, and we really focus in the rev cycle space and the HIT space, our buyers are typically CFOs and CEOs. What they've seen and they're sharing with us is the cash flow. I'd say this quarter, compared to the prior quarters, has been significant slowdown in cash flow, and that's directly from the payers. Clearly, we all know on this panel where the denials have been over the past couple of years. On the denial side, we've seen a 30+% increase from last year, 2024 versus 2025. So it's really been significant. And some of the technology providers on the call, you just have to apply more tools from an automation perspective. You also, listening to the panel, from a payer perspective, going more tactically from a contract management and having the right tools to really understand where the variances are in granularity. And therefore, when you're doing that kind of granularity, your team members have to be a lot more knowledgeable about the space, a lot more knowledgeable about the space. So I'll stop there because this is probably an area that we could spend an hour on.
All right, thank you so much. We're off to a great start. So, for our second question of the day, with so many disparate systems, EHRs, billing software, clearinghouses, how can leaders ensure their technology stack is actually working with each other effectively? And Megan, we'll have you start us off with this.
I feel if you really want to measure how well your systems are working together, you can try to do some sort of a technical analysis. Are things integrated well? Is data flowing appropriately? But I'm not sure that that really is a good measurement ultimately of whether the systems are speaking. I think that the true test of that is the data and the results and the outcomes. Are we seeing less denials? Are we experiencing less rework? If not, all the systems can be flowing together perfectly, but if they're not intervening at the right time in the right way, actually creating the positive outcomes you're looking for, I think that even with the best integrated system, that can still create challenges. So I think showing that you really have a tech stack that flows together shows in the ultimate, outcomes of that tech stack.
Great points there, Megan. Anything to add here, Tom, to what Megan just said with this question? No, Tom, you're on mute again.
Thank you,
All
ma'am.
right.
Yeah, I would definitely say in this space, having a revenue and a clinical data governance is huge, regardless of the size of the organization. I know larger health systems that we've worked with over the years have very sophisticated data governance, but that really will help with the single source of truth. So when you look in the clinical side or the revenue cycle side, I'll speak to the revenue cycle side because we don't really focus on the clinical perspective. It is critical to have a single source of truth, and I'll leave it at that.
Thanks, Tom. Courtney, anything to add there?
Yeah, absolutely. And Megan and Tom definitely hit the nail on the head with what I was going to share. To add to that, I think, communication is number one, just ensuring that, there's successful implementation, correct processes and project management from a workflow standpoint. Often, we see that accuracy is lost when, patient demographics or insurance changes made in the AHRs don't flow immediately over to the billing systems, which could, reduce trust. And there's so much storytelling on our side of RCM, but if the data doesn't speak to each other, there's hindrances on being able to have the clear story behind it from a performance visibility as well. So just making sure that everything is augmented correctly and continuing to kind of ask the question that we find in our operations of, if the system that we have is a source of truth, is it siloed, or if the systems we have, can they hold up under pressure? If volume doubled down tomorrow, what areas would actually, be our first point of review and to stay engaged with those operations as well.
Thanks, Courtney. Greg, anything to add?
I think that I'm probably going to say the same thing in different words as some of the other panelists have talked about. But the way I think about this question is that it's really important to think about data as its own tool, separate from the source systems or the user interface systems that might be creating that data. Particularly, again, with the small and mid-sized companies that we work with, they don't necessarily have a ton of healthcare IT resource. They don't necessarily have a ton of infrastructure, and they likely are using these fragmented systems that behavioral healthcare was one of the areas not subject to meaningful use, and so there isn't necessarily great interoperability between the systems that our client companies are using. And so, where we've invested our time and energy and capital from a tech standpoint is in developing that data layer that allows us to provide that infrastructure and support. Because as everybody has already said, the integrity of the data and the consistency of the data, and the speed with which the data can be updated, extracted, integrated, is really critical, and that's a tool that is really not often thought of, at least by the folks that we work with, as its own value driver. And so we always are helping people understand that the EHR is important, the billing system is important, the CRM is important, but having that data layer that crosses all of those things is its own problem to solve. And you aren't necessarily going to get that through native integration between those systems.
All right. Well, switching gears now, what are practical ways to reduce administrative burnout without increasing headcount? And Tom, I'll have you start us off with this.
Sure, this is obviously a huge topic when you look at burnout right now from an industry perspective. It's in the 40% range, so it is extremely material at this stage. I think some of the things that we're beginning to see, and I'll give you some real examples of how to get really from an AI and an automation perspective, specifically for providers. What we're seeing is beginning to do smaller pilots with documentation. So when you look at the industry today, physicians will spend 30 to 40% of their time just on paperwork, just on the documentation itself. And so what we're talking to some of our providers about and seeing is how you can take really documentation from systems and then when you're doing the documentation from a PDF perspective and actually using AI, true AI, to help with I'll just say workflow and help specific with the documentation itself at the end of your patient rounds. And what we've seen, we've actually spoken to some physicians that it saves them an hour to 2 hours a day giving back. So because as physicians are doing rounds at the end of the day, everybody does their documentation at the end of the day, and it has been very, 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 I'd say very, very successful. I think a lot of people wonder, differing age brackets of physicians. Will the AI be adopted by, let's just say, the older population? And it's actually it's been quite the opposite because of the savings.
Thanks for starting us off, Tom. Up next, Megan.
Yeah, I agree with a lot of what Tom said, but ultimately all of it is moot as much as we try to identify and fix upstream. If it's not delivered in a way that providers will accept, that they like, that is delivered in their workflow natively, that it has the provider like truly at mind. A lot of people have great solutions that unfortunately just their effectiveness dies when it comes to the lack of provider adoption to it. And that's the key to all of it. What do we need to have providers spend time on? What shouldn't be spent time on? How do we not cast wide nets with what we want providers to look at? How do we have very targeted, curated solutions that are as effective for them to be able to participate with as possible? One of our solutions we're very proud has over 70% provider adoption rate. We have never seen that historically at IMO, like with any of our provider facing solutions, but because we have learned and taken feedback and have tried to spend that time and spend those clicks on areas that are going to directly alleviate and eliminate pain points for them downstream. And if it's delivered to them in the right way, we find that there is good adoption to the content that we surface, but there's so much, a little bit of art and a little bit of science to actually getting people to intervene on these things. And that's going to be the true way to reduce administrative burden, is by improving these things at the place that it starts. I mean, that's really the only way to do it. Get as upstream as possible. And that's the hardest place to do it. So that's the challenge for all of us.
Thanks, Megan. Greg, any practical ways to share?
Yeah, I think just echoing some of the things that Megan just mentioned, I think that our executive leadership team was just together over the last couple of days, and we had a presentation from one of our technology partners that's helping us implement AI into our workflows. And they said something in their presentation that really stuck with me, which is to really emphasize the distinction between jobs and tasks. And Megan was sort of talking about figuring out, how do you find the right scope to apply these tools. One of the things that really has been percolating in my mind since I sat in this presentation in the last couple of days is this idea that everybody's job role, whether you are in clinical practice, whether you're in revenue cycle, administration, wherever you are, it sort of boils down ultimately to a collection of tasks. And some of those tasks are highly automatable and would frankly you'd be much happier if they were automated. And some of those tasks aren't ultimately automatable. And I think that really understanding the process flow and the job roles and sort of figuring out which tasks are automatable and honing in on those and allowing folks to practice at the top of their license, as you might say, I think is a really impactful way both to reduce the administrative burden and I think to create an incentive for adoption. And the second thing that I'll say is that one of the things that we have implemented with our team is in behavioral healthcare, utilization management is an extremely labor-intensive, qualitative process. There's a lot of chart review that has to happen. There's not quite every these days, but almost every interaction with the payers has to take place with a live human being over the phone. And so our UR team spends a lot of time reviewing documents, collating information, assembling their sort of like case, so to speak, for the payers. And one of the tools that we've implemented, AI tools that we've implemented, is one that sort of has learned from observing our team what needs to go into that packet of information, and then we'll be able to go into the charts and review them and sort of produce that on behalf of our UR folks. That is allowing each of our team members to increase their caseload by 50 to 100%. And it has. So our team is very excited about it for a variety of reasons. It takes a lot of the busy work out of their jobs, and it allows them to do more of the thing that matters to them, which is to obtain authorization for more services for their patients that they're working on behalf of. But the other thing that it does for our client facilities, which is, if you think about adoption, there's really two levels of adoption. There's the user adoption, but there's also the organizational adoption. And many healthcare providers are skeptical around AI for a variety of reasons, some good, some bad. But our client facilities are very excited about this tool because it's also alleviating their compliance burden. At the same time as this tool is reading charts and compiling information for our team to do utilization management, it's also comparing the contents of the charts against payer requirements, and identifying places where the charting is maybe inadequate or incomplete. And that saves denials and other issues further down the line. And so the lesson that I take from that is there sort of is a win all the way around for all of the participants in the ecosystem with respect to that tool, particularly that we've implemented. And so I think that's another interesting lesson that we've learned in how to drive adoption, is sort of like consider all of the perspectives and make sure that there's a benefit for everybody.
Thank you, Greg. Courtney, any final thoughts here?
Yes, and I will also just echo on what everybody said as well, because this is a question that I love most. Like Megan said, keeping physicians and providers in mind with reducing admin burnout. we continue to see at MedCycle the adoption increase across the board with our clients as well. And by just keeping that long-term strategy with what tools we're going to implement with and scaling operations without sacrificing a team. Because a lot of the times what I've noticed managing in an operations is the question becomes, is it burnout or is it fatigue? Burnout can begin in a ton of different places, as well as in the mindset of, repetitive tasks, and also a state of overwhelm with too many tasks and having those roles and workflow processes be unclear. So at MedCycle, we've continued to build out technology to kind of eliminate fatigue around workflow, whether it's through RPAs, for example, to allow different spaces to remove the repetitive task and to handle those, and focusing on how well we can transition practices and people to be relieved, where in certain areas, maybe bots can handle different routines with systematic processes, payment IVRs or payer portals, and then the cognitive load of backlogged AR, freeing up the staff to act in the roles that they're, driven for, high-level analysts and billing specialists. Our insurance department has implemented technology for more efficiency with claim status and denial resolution, which has also allowed the team to reduce their time spending verifying claim statuses, actions on accounts, and then our clients implementing those as well from some of the tasks that Tom highlighted too.
All right. Well, thank you everyone for your nuggets of truth in such an important question. But this is the last of the questions I'm going to ask before opening it up to our wonderful audience. So this would be a great time to get those questions in so we can try to address as many as possible. For our next question, I'll have Greg start. How can healthcare teams effectively balance strict security compliance with the operational efficiency needed to keep the revenue cycle moving?
I think that my answer to this question is going to be fairly elementary. I'm certainly no compliance expert, but all of the experiences that I've had and all the people that I've talked to about this have sort of suggested that the same thing is true now that has always been true, which is that ultimately humans are the weakest link in our security chain. We do. For years, companies have been doing regular phishing testing and education around, again, like education and training around sort of like human susceptibility to compliance breaches. And I think that continues to be true with AI. One of the things that we learned about from our AI partner in this recent presentation was how to go about thinking about AI governance, policies and procedures around AI. Some of that is very simple, which is to say, most folks have most organizations have some form of user access control or administrative control over what you can download onto your machine. So have approved tools and tools that are not approved, and restrict people's ability to use the tools that are not approved. But there's obviously a lot more to it than that, and so I think that really the focus for us in our organization is not just sort of developing the right technical safeguards, but also developing the right safeguards and training around human behavior and making sure that we're not that our team is not unintentionally exposing us or our clients to risk around that.
Thanks for starting us off, Greg. Up next, Courtney.
Yeah, so I think it may be a two-part to address, right? So one would be externally, partnering with trusted tech providers and organizations that truly understand healthcare regulations is going to be number one. So once your systems are up and ready for go live, you and the client have confidence that you're set up for success and you are compliant. So it's really important to be sure that those, trusted tech providers do understand the full scope, and you're asking for their credentials and their regulations and, high trust, PHI, PCI compliance and such like that. And then part two, I would say, would be internally. So kind of echoing Greg on that, working with internal users to understand, what the need is of the role, securely setting expectations by communicating, what secure data handling looks like, understanding the need of the teamwork, the process, proper encryption through best security practices, whether it's MFA, VPN, zero trust, and having a plan of action for proper incident response plans if that should have to happen. Just reinforcing accountability by partnering with the right individuals in IT during audits and implementing, any required updates to secure endpoints.
All right. Tom, anything to add to what Courtney and Greg just said?
Yeah, I would completely agree with both what Courtney just said as well as Greg. Greg, you kind of simplified things on the people side, but the people side is obviously the hardest side. But I'll speak to what we do internally, and then I'll speak to Courtney's point about really technology vendors, and we all work with hospitals. But I would say from what we've seen over the last 10 years, I'll speak to that first, is really the importance of really having cross-functional leadership and governance around this area. So when I say cross-functional, so from our perspective, having a cyber officer, having somebody that actually then owns security policies from a HIPAA perspective, and clearly from an IT security side. So when we look at this, we think of the importance of doing assessments on your operations annually. We look at training education quarterly, and annual and obviously annual education for employees and team members. And I'd say the third thing is really having security protocols in place. But probably the most important thing is you have to make it simple for your team members and your employees. And so when I say simple, you need to do frequent education. So for us, we push stuff out weekly, definitely monthly. And the importance of that is it's got to be top of mind, because you can spend all the money in the world on security, best technology in the world, but at the end of the day, every one of us have access to computers inside and outside the organization, and that's where the security really has to start. To Greg's earlier point, so I can't overemphasize that. We spend a lot of energy internally on this. I talk to customers about this, because in large revenue cycle organizations and hospitals, it's challenging because you have turnover. But most importantly, it just has to be, you have to have a policy and a program that leadership drives. So I'll leave it at that.
Thank you, Tom. Last but not the least, Megan, anything to finally say?
Yeah, kind of like what Greg said. I mean, I don't oversee tons in our security and compliance areas, and so I won't speak too out of turn. But I guess I would talk from our company's perspective on it, from how I observe it, and that's that we invest very heavily in security and InfoSec. I mean, we have a very robust team that we're adding to all the time. I see them always going to different conferences, attending different virtual events. I mean, you have to stay not just up with the curve, ahead of the curve when it comes to this, because in all industries, ultimately there's security concerns, but financial industry probably being a huge one as well. But healthcare, that's really up there in the, way that we need to handle the data that we have access to, because ultimately when these breaches happen and things fall out, it really impacts the patient. Of course it impacts the systems and all the administrative cost and frustration and everything that it takes to, kind of clean something up after it happens. But a lot of that rolls down to the patient experience. And so it's always everybody's goal to keep things tight. I think, Courtney, you kind of mentioned about it's like just maintain a lot of communication though among all the stakeholders. And Tom, you mentioned around, not just, enforcing it the first time, but that reinforcement consistently. Even sometimes I get it too, a little bit of not necessarily security fatigue, but but it's like, it's important, and it's important to constantly keep these concepts fresh in our mind and to always be talking about it. And the last thing is, just as a vendor, it's our responsibility, to bring products to market that are secure, and maintaining and investing in that. And that's what we need to do for our partners. And then they owe us back that, 50-50, meet as well, to ensure that they have a secure system. But ultimately, I think it does start a lot with the vendor ownership over the solutions that we bring to market.
Thanks, everyone. Okay, the moment I'm sure many of you were waiting for, our Q&A portion. Reminder, you can continue to send in questions as we go through. We will work on answering as many as we can. But for now, since I am not seeing any questions in the chat, we will prioritize some of the questions sent off during our pre-panel survey that we sent out. So it says here, how does the quality of one's revenue cycle directly impact patient experience and satisfaction? And Tom, we'll have you start us off with this.
Um, when I think about patient satisfaction, and it directly ties to, I'll say, the patient access department. So when a patient comes through the hospital, it's, this is kind of near and dear to us, and we're big advocates of having that function being served as by employees of the community, employees of the hospital, as opposed to outsourced. And so, what I mean by that is the patient experience. That there's stats that when you really take your time with a patient and you really go through what the billings would be and what the upfront cost would be, and you spend that time, the probability of having a from a satisfaction perspective is, it's 70 to 80% probable that you will have a satisfied patient coming through the door. So that's why we've over the years spent a lot of times with our customers, really focused in that area, because that's really where it starts. And there's tools, there's lots of tools that you can apply, and I'll let other folks on the call speak to that, but I'll leave it at that for now. And I'll just say that, from an AI perspective, there's so many things that we're seeing in the space, from an automation AI, advanced preparation before patients are coming to the hospital, just pushing stuff out via text, or just obtaining data before they're there to really help the experience. But I'll stop there.
Thank you, Tom. Any thoughts, Greg?
I will certainly agree that patient education and engagement pre-admission, and also during the course of treatment as well, is a really, really critical driver here. That's definitely something that that the programs that we work with have experienced, and somebody that I know in the behavioral health industry always likes to talk about how, you know, unfortunately, many of the conditions that our clients treat are chronic lifetime conditions. It's substance use addiction, it's mental health disorders. And so very likely, even after they discharge from treatment, they will be back in treatment of some form at some point in their life. And one of the folks in the industry that I talk to about this likes to say that, if the last interaction that your patient has with you is to get a big bill that they didn't expect, what do you think is the likelihood that it will come back to your program when they need treatment later on down the line? And so I think, I completely agree with Tom's perspective on that. I think the other thing that I will say, again, specifically to the sort of behavioral health world, is that, the utilization management is such an important component of the programs that we work with, because they are typically, I'm thinking particularly about the inpatient programs where folks come in for detox and residential substance use treatment, for example. They're planning to be in treatment for 30 days. There's a 30-day, sort of clinical program that's outlined, and a treatment plan that's sort of established at the beginning of the stay. But our team or our client teams are doing authorization, need to reauthorize every 3 to 5 days during the course of that. And very often we don't get exactly the authorization that aligns with the clinical programming or with the treatment plan. And so staying in active communication with the client and the client's families, which is really important for behavioral health care, during the course of treatment, around progress and changes to the treatment plan, and sort of, again, I think it's really just about helping educate the patient around how the RCM process is impacting their treatment experience, and keeping them informed and keeping them in the loop on that as it's developing, rather than sort of letting it hit them after the fact as a surprise. Oh, it's time to discharge unexpectedly. Oh, you need to step down to a lower level of care. So that engagement and education, I think, is just sort of the common theme through that.
All right. Megan, what's your take here?
Yeah, I mean, I agree with some of the unique aspects that both Tom and Greg have brought up. I think that from my side, where I feel it most, we do a lot of work in the oncology space, and it is really, disheartening to see how many patients ultimately walk away from their treatment plans because of financial reasons. And sometimes that's not always, I mean, really never legitimate, but sometimes really not legitimate in that they're not appropriately being denied. There's medical necessity issues. There's more administrative details that are actually causing them to either have a delay in their care or be given an unexpected, sometimes inaccurate bill that actually makes them intervene and not choose that care path that could be best for them. And I mean, the stats are really, really disheartening that come out of the oncology space of how many people stop their treatment because of financial reasons. And so having a healthy rev cycle helps support our patients to be sure that they're having access to the care that they should at the cost that is appropriate for them, and so that we can do what we can to make sure that nobody is making patient care decisions based off of what may or may not have gotten denied, which is a reality that we live with today. So how can we improve our documentation up front? How can we leverage all of the rules that are out there for things like medical necessity to build in more content, more solutions that are integrated into the workflow so that we can identify further upstream and give patients access to their care in a timely manner?
Thanks, Greg and Megan. And finally, Courtney, any final thoughts?
Yes. The patient journey isn't always linear. At MedCycle, we provide custom revenue cycle solutions to meet our client needs and prioritize that we're insured and aligned. Because our focus is to ensure that every partnership translates and each patient experience into a seamless, high impact experience. Overseeing the revenue cycle from an early out standpoint, and from an ops hat as well, focusing on practical and thoughtful framework. Keeping the patient in your vision and woven into your mission is huge. Like I always say, you have to think as the patient, because we are all patients as well. And Greg mentioned, the patient may have this great compassionate service experience with their provider, and then 30, 60, 90 days later, they get this cold, awful bill to their surprise. And as Megan said, to reiterate that, from a psychological standpoint, how that impacts the patient care and the fear around the patient of what their satisfaction is going to be like, what their experience in the future is going to be like. Patients continue to deserve at every point of the revenue cycle, life cycle, the one-on-one patient care, customer service, digital options, and frictionless experiences where on the back end with AR, you can feel when there's chaos or there's organized chaos in the quality of framework on the back end. And so a lot of that quality starts with the leadership and the right roles, revenue cycle embodying how the quality is or lack of influencing the workflow around that with the patient. And we see it all the time too, whether it's through surveys or our one-on-one, inbound, outbound activity calls that we have to our patients, how their experience was. And it takes one poor experience, one confused call or an unclear bill to really rattle the entire life cycle of that. So our goal and our role is to really enforce the strategic conversations and the support around patient care when it comes to front end, middle, and back end of revenue cycle. So I hope that was clear. There's so much to always be said around that. So to encompass that into a couple of minutes, I think what I've heard is perfect from everybody on this panel.
All right. We are going to wrap up this portion of the panel now so we can stick to our schedule. If we don't get to your questions, or if you have questions specific to your organization, we want to make sure you get connected with the relevant team to answer them. We have just sent, or we are about to send, a quick survey to you in the chat where you can indicate which panelists you particularly want to hear from after the session, as well as provide any feedback on the panel. I'll share your interest with the relevant panelists after this session. I've had such an insightful time hearing from our panelists today, and so I'm hoping to get one final piece of insight from them all. As the industry continues to shift towards value-based care, how does the revenue cycle need to adapt to support that model? And please let our audience know where they can find you and your organization. Let's start off with Tom.
Sure. Thank you for the question. From a value-based perspective, very complex topic. It's very complex. When I think about the Medicare Advantage penetration into the space, don't quote me on these facts, but I think when you look at from the value-based and the capitation payments from a couple of years ago, about 4 years back, they was right in about 7 to 8%. Now it's pushing to the 14 to 15% of healthcare payments. So that has been definitely an increase. It hasn't been probably at the speed of I would thought other providers would have thought it would have been, but it definitely because we would have expected. I'll speak on behalf. I've been in the value-based side for 20 years, and it just when you look at 2021 to current space, it's a large space, but I give that background for this point, and the point is around the data, and the point is around really having predictive analytics. And now that we're in the space, AI has been around a long time. Payers have been using it for years, absolutely years. And so when you really think about today's space, you really have to have. You talk about data governance. We talked a little bit about that before, but you really have to have a model that you're able to collect all pieces for clinical. Clearly, what Greg's spoken about a lot today around utilization. Obviously, the back end, the financial side. And you really have to have algorithms in this area, in the analytics tools to help you not only manage the cost, but begin to manage, I'll say, your portfolio of services. So I'll stop there.
Tom, thank you so much for your time and sharing your expertise. Greg, final thoughts and insights.
Yeah, so just to quickly say, you can find me and Prosperity at prosperitybh.com. And I see that my LinkedIn is in the chat as well, so please feel free to reach out to me through that medium as well. In behavioral healthcare specifically, value-based care has been very slow to manifest. And there's been a lot of discussion about it over many years, and we see very, very few models of working value-based arrangements with payers. And so that has led to, I think, a certain amount of being jaded and a certain amount of cynicism in the behavioral health space around this. That's not to say that it will never happen. It is coming. And I think the way that it's going to impact the RCM for behavioral healthcare specifically is that historically RCM has not been thought of as a strategic priority for the businesses that we work with. They're thinking about patient acquisition. They're thinking about clinical programming. They don't think of RCM. They think of RCM as essentially a necessary evil very often. And I think that as value-based care starts to manifest in behavioral health care, the RCM leaders, whether they're internal or external, are going to need to become strategic partners with executive teams to understand the risk models, understand the variables, because it's simply a muscle that hasn't been developed in a lot of our partner organizations, a lot of organizations in our field. And so that strategic partnership is going to be a thought partnership. It's going to be a data partnership. It's going to be an analytical partnership. And it may also be a partnership built around tools and integration of tools, because one of the things that, again, behavioral healthcare really has has struggled with adoption around is outcomes monitoring for patients. We are, our field is much more qualitative, much less quantitative than many, and that poses real challenges for measuring long-term patient outcomes. And so there have been some technology tools that have started to come to market in that area in recent years. There's been pretty low adoption of those tools, and part of the reason is because the value proposition hasn't been clear. And so RCM leaders helping executive teams understand the value proposition of implementing those tools, implementing them early, getting them set up right so that when value-based care does become more of a driving force in the space, you have that data, you can build those models, you can have that sort of strategic conversation that Tom was alluding to.
Thank you for your valuable insights, Greg, and for your time. Megan, final piece of advice.
Not too much to add outside of what the other panelists just shared. I mean, at IMO, we just see how much administrative burden is caused from trying to find diagnoses, for HCCs. And so as much as we can use automated tools to prompt for those proactively, prompt for what is undocumented out of the data that is there and get it into a discrete format, it's just going to be the very first step, I think, in building out a model that allows you to be able to participate in value-based care in a way that ultimately should benefit you and your providers and your patients is the goal of value-based care. If we can get to that goal, though, starts with that rich data, but we need to give them tools to help them find those undocumented conditions. So that's I think Tom kind of mentioned it's a highly complex issue. There's a million different points within it and gaps within it and areas that are going to have to work together in order to make the concept of value-based care work. And so that's just kind of the one area that we have chosen to focus on here at IMO. So I work at IMO Health. You can always find me via our sales email, which is sales@imohealth.com. But I saw that my LinkedIn's in the chat. That's the easiest way to get a hold of me. I'm pretty active on LinkedIn, so just let me know if there's ever anything that you would want to talk about. Thanks for having me today.
Megan, thank you for extending your time and wisdom for us today. And of course, Courtney, any last thoughts?
Yes, and I'll just close out with recapping everything that everyone had shared as well, just continuing to refine workforce models on how we can bridge the gap for patients, providers, and RCMs staying integrated, keeping value-based what it is based around value, keeping the patient in mind first and foremost with the new ways to communicate, especially as we move deeper into a digital communication, omni-channel space, and what that looks like. Continuing just focusing on capacity with the correct strategy for long-term roles and automation as we adopt what that sustainability will look like in the next 6 months, 12 months, 5, 10 years. And then continuing to invest in the right people, hiring the right traits and skill sets. A lot of the times, as we all know here, if we don't solve the operational and financial challenge first, then we do risk the long-term effects and sustainability of healthcare in the communities we serve. So since the goal for technology is to ultimately be an enabler and not the inhibitor, just continuing to stay on top with quality and leadership, making sure open lines of communication stay, that we're designing the right workflow, and we're modifying to keep value-based in the foundation as we all evolve. So I appreciate being on the panel with everyone, and a couple ways you can find me. I'm on LinkedIn. I think that was dropped, as Greg said, in the chat, and then on our MedCycle management website, mc-mgmt.com. I am always open for conversation, so thank you.
Thank you so much, Courtney, for sharing time with the NX Unite community. And with that, we have reached the end of our panel. I want to give a big thank you to our panelists for sharing their insights today. I also want to thank everyone who attended today's panel. I hope you enjoyed yourself and learned something that will benefit the work you do on a daily basis. We have a packed few months of panels ahead of us, and I hope you will join us for them. Keep an eye on the NX Unite community platform or the NX Unite LinkedIn page to make sure you don't miss out on any of these. Better yet, go sign up now. It takes one click to RSVP once you're logged in. It has been a pleasure speaking with you all. Have a nice day. Bye.
Nice to meet you. Bye-bye.
Bye-bye.